In this video, we are going to discuss bias, its types, sources, and reduction of bias through different approaches. And to start with, we are going to define bias as a systematic difference between observed results and the actual results. Actually, this is one of the most important disadvantages of many of the designs, especially the case control design and also the cross-section surveys and others. And also bias is important in clinical trials, as if biased results are there, this will render the whole outcome of the trial questionable. So it is a systematic difference between the uh, observed results and the actual results that we are getting, and several types of bias exist in research. And as mentioned by Sakit and Ital, have listed about 19 types of bias commonly encountered in epidemiological studies, different designs. And Choi had expanded the list to 65 types of bias, and indeed any type of error introduced in the study for which a cause can be identified could be potentially considered as bias by definition. That's systematic error, as we can talk about. And many of these biases are hard to detect, even harder to avoid. So they are inevitable to avoid most of the sources of bias. And here we are going to consider about three types of biases which are commonly encountered in research and will be of importance for us to understand what exactly these sources and how we can avoid them in conduct of the research. We have the selection bias, and this is a distortion of the estimate of effect resulting from the manner in which the study population is selected. And this is probably the most common encountered type of bias in health research and medical research, and occurs in analytical and experimental study designs as well. And the second one is the prevalence incidence bias. And this type of bias can be introduced into a case control study as a result of selective survivals among the relevant prevalent cases. And in selecting cases, we are having a late look at the disease. For example, if the exposure occurs year before, so mild cases that improve or other cases, severe cases that died already, would have been missed, would not be included or encountered among the cases. And this result is what we call the prevalence incidence, because in this case, we are going to enroll cases from those who survive, and then we missed the mild cases that improved, and as well as the severe cases who died. And this is a very important source of bias in case control study design. And this bias is often a problem, is not a problem in cohort studies but or experimental study designs, but this is very commonly encountered in case control as we deal with cases. So we miss the mild cases, and as well as the died cases also, we miss them. Also, we talk about the admission rate or Parkinson's bias, and this type of bias is due to selective factors of admission to hospitals and occur in hospital-based studies. And many case control studies collect cases from hospitals and identify controls as well from those attendants of the hospital from other departments or other wards or other clinics, or admitted to some other reasons. So here the bias may be the burden of symptoms that is very important, that the cases they are suffering from symptoms, so they are admitted, and as well as access to care. Those who access the care will come to hospital, and this will lead to bias that the cases we encountered and the controls are not representative of the parent population. And also there are variation in admission policies and practices in different health facilities, especially in the private hospitals, that so many people are the practices there are different from, for example, from the public hospitals. And so this will result in what we call it per concerns bias. Also, we have non-response bias, and this is due to non-response from some of the participants in the study, and the individual concerned are likely to be different from those who participated. Yani, in some other words, we have, if we have very high non-response rate, that there are so many participants who do not respond, and their characteristics and their responses may be different from those participants who responded to the survey. And non-respondents must be compared with respondents with regard to key exposure and outcome variables in order to ascertain the relative degree of non-response bias. Non-response bias is common in all types of studies, but is more serious in observational studies, particularly in cross-sectional surveys. They are always suffering from such non-response bias. The information bias is another source. It is a distortion in the estimate of effect due to measurement error or misclassification of subjects according to one or more variables. Well, we have here two important types of information bias: the diagnostic bias and the recall bias. We can talk about the diagnostic bias that may occur due to performance of a disproportionately high number of diagnostic procedures on cases as compared to controls. For example, if we are looking for CA bladder or CA breast or any types of malignancy, then for the cases we are carrying so many investigations to detect whether this is malignant, this case is suffering from malignancy or not. And on the other side, for the controls, we are carrying the minimal number of diagnostic procedures. And in a cohort study, knowledge of a subject prior to exposure to a possible cause may influence both the intensity and outcome diagnostic procedure, especially in a cohort study. If the data collector or the interviewer, they come to know that this individual had been exposed to the factor suspected to be etiologically associated, then also they will dig deeply, asking so many questions. They will carry many investigations so that they can detect whether this individual has developed the disease or not. In contrast to the cases, very minimal investigations are carried to detect the condition. In a case control study, if the disease outcome is one with few clinical manifestations or clinical picture is limited, and few symptoms and signs, and thus to diagnose the case, this is required intensive laboratory test or diagnostic procedure to detect. Thus, the disease may be missed in the control group if they are not adequately examined prior to inclusion in the study. For example, in order to ascertain the presence of endometrial cancer, individual exposed or not exposed to estrogen therapy, for example, the same diagnostic procedure must be performed for both the cases and the controls. In other words, we need the bias can be reduced by having the control group selected from those persons who went through or undergo the same diagnostic procedures as did the case group, and by using only those who showed negative results as control. In this way, we can reduce the bias in such situations. We have also the recall bias and error in categorization of the may occur if information exposure is unknown or inaccurate. A certain amount of exposure to drugs by history alone, and the more intense search of investigation, a more intense search by investigator for exposure variable among cases may lead to this type of bias, what we call it recall bias. And the recall bias by both cases and controls may differ in amount and accuracy, especially that if cases they come to know that their their exposure is related to the disease, then they will recall the information about the bias in different manner than the cases who are not suffering from the disease exactly. Now we talk about the sources and bias that we have in clinical trial. The participant bias would be a source. The participant reports subjectively that they feel better or improved if they come to know that they were receiving new treatment in the trial. And also we have the observer bias, and here the influence of investigator measuring the outcome of the trial. If he or she knew beforehand the particular procedure with which the patient has been subjected. In other words, they know that this is a case, or this is within the treatment group, this subject within the treatment group or in the control group. So this will cause some sort of bias in observing the outcome of the result. Also, they may be biased in evaluation, as the investigator may involuntarily give favorable report of the outcome of the study. And also those who are carrying the analysis also may be a source of bias for the outcome of the result. Now we'll talk how to reduce the sources of bias through randomization or random allocation or blinding. And we'll talk about the two, because we have to know at first the relevant group who may or may not have knowledge of treatment assignments or allocation. For example, the participant, and this could be a source of bias, the investigators, the clinicians administering the intervention also, this may be a source of bias, or the investigator assessing the outcomes. This may be another source of bias in assessing the outcome of the trial. And also the data analysts who are carrying the data analysis, if they come to know beforehand who is in the treatment group and who is in the control group. We talk also about the open trials in which all participants and investigators and evaluators, they know who is getting which intervention. For example, who is getting medical intervention, who is getting surgical intervention, who is getting placebo, and this is what we call the open clinical trials. The blinding is carried out in three ways. We can talk about single blind trial, and here the trial is so planned that the participant is not aware whether he or she belongs to the study or control group. And also, we can talk about the double-blind trial. In such a trial is so planned that neither the doctor who is giving the treatment nor the participant is aware of the group allocation and treatment received. And then we talk about the triple-blind trial, and the trial is so planned that the participant, the investigators, and the person carrying the analysis or the analyst of the data are all blind. They don't know who belongs to the treatment group and who belongs to the control group. And this is the ideal, but double-blind trial is the most commonly used. Advantages of blinding is that they protect against performance and reporting bias, whether it is in data collection, in follow-up, in the outcome assessment of the trial, reporting of the outcome, or for example, other care received during the trial, or interpretation of the results. These are very important sources of biases that can be protected through masking or blinding, as we have mentioned. The disadvantages of blinding is that may be logistically or ethically impossible and may not reflect clinical care practices as well, and it increases the cost of the trial definitely. Now we talk about another aspect, which is concealment of the allocation versus blinding. And we'll talk about the concealment of allocation. Concealment is the procedure to protect randomization process or random allocation process before the subject enters or enrolled in the trial, before random allocation is carried out. It is the technique of ensuring that implementation of random allocation sequence occurs without knowledge of which patient will receive which treatment. And the purpose of concealment is to prevent selection bias by ensuring that the allocation process is not influenced by the researcher or participant. And using, for example, sealed opaque envelopes or a centralized computer system to assign treatments so that the person enrolling participant doesn't know exactly the upcoming assignment of whom of which. Concealment of allocation is always visible, and if not done, results in selection bias. Randomization benefits are lost or reduced, and treatment assignment is no longer truly random. What are the acceptable ways to ensure concealment? Is that we have central randomization, and in this technique, the individual recruiting the patient contacts a central method center by phone or computer system after the patient is enrolled. Sequentially numbered opaque sealed envelopes also can be used, and this method is generally accepted by most of the investigators in clinical trial especially. Blinding is masking the treatments after random allocation once the trial begins. And the purpose here is to reduce the bias in treatment administration, patient behavior, and the outcome of the trial. And blinding is not always visible, and if not done, can result in patients in biasing their responses because of their knowledge beforehand of the treatment they receive, whether it's new treatment or not, and can also lead to biased outcome assessment because investigators who are assessing the outcome of the trial have knowledge about the type of treatment received by whom. And now we can talk about the key differences between concealment and blinding. We can talk about for example, the concealment usually is before random allocation and blinding is after random allocation. And the purpose of concealment is to prevent selection bias through concealing randomization sequence. And the blinding prevents performance and measurement bias, or what we call it observation bias, through masking participants or investigator or both of the received treatment. Who is affected? Usually concealment. The researcher during the allocation are affected by the concealment, while blinding is usually affecting the participant, clinician, and analyst so that they become blind towards the treatment. Thank you very much.